So I graduated from IPTA in '99 with my master's and had a brief little stint in outpatient ortho up in Oswego. And then I started at Upstate as a rotating PT, which was a great experience. So I pretty much worked everywhere, burn unit, cardiac, everything but pediatrics. Then ended up for about 10 years in outpatient neuro, so more severe TBI, spinal cord injury, stroke, amputation, things like that. And then the last couple of years transitioned just to outpatient concussion management, which actually compared to some of the other, even though we're talking a less severe type of injury, for me it was a bit more challenging to work with. Something that, no clear-cut injury and, no clear-cut etiology a lot of times. So I put together a presentation. I certainly will answer questions throughout. My focus is, my overall goal for the presentation is to have you at least able to identify maybe some patients that you're treating perhaps for shoulder injury or neck injury, maybe from a car accident, that might actually have some concussion symptoms present. So I think that's a really applicable goal from this talk. And then also, if you are treating these patients, is anyone actively treating concussion patients that come with the diagnosis? Okay, great. How about who's had a concussion? Okay. So you might really, see some of yourself in this talk. I also try to add a little bit more. I'm going to go over some of the evaluation techniques and screening, vision, vestibular, that type of thing. But I really added some, I think, good content on exercise, so provocative exercise testing, and then exercise prescription for concussion management. So we're going to look at the definition, which can be a little gray and is, like a lot of things, most people don't walk through the door with the definition or a diagnosis of a concussion. Even if you work in the concussion management program at Upstate, it is kind of hard to diagnose it. We're going to look at some of the common domains of symptoms, so we will discuss that. And I'm going to talk a little bit about our concussion management team at Upstate, some of the important parts to kind of address the whole patient, because you'll see some of the symptoms are outside of the physical realm. So we might need some psychological support, things like that. We're going to talk about the provocative exercise test. I'm going to go through in detail the Buffalo concussion treadmill test, and then talk about treatment techniques, progression, and some of the challenges that we face with this population. So the definition, and I included two different definitions here, again, just to kind of key you in that sometimes it is a little bit gray. So the first one, just to know that the top lower jolt to the head needs to occur, and then it's and one of the following. So it's a lower jolt to the head and either a loss of consciousness, less than 30 minutes, or post-traumatic amnesia, less than 24 hours, or a neurological finding, maybe a change in vision, blurring of the speech, something like that, or an alteration in mental state. So it could be any of those things, and that can be, I was foggy, I was dazed, I was confused. Some of these things, if it's a sports concussion and there's a team around you, they may be able to say, yeah, they were definitely confused or they definitely passed out for a second. But if this is a car accident or nobody else witnesses it, it's really hard to make that diagnosis. But the key is after 30 minutes, they do have the Glasgow Coma scale of 13 to 15, so minimal mini TBI. So I included this other definition as well. So I think this one just kind of reiterates the fact that I like the impulsive force transmitted to the head here, because they don't actually have to hit their head. We see a lot of whiplash type of injuries that end up with concussion symptoms. So I think that's important to realize. And also, I included this one because it explains functional disturbances in the workings of the brain versus a structural disturbance. So these folks, if they have a CT or an MRI, usually there are no findings that show up. And again, it may or may not involve a loss of consciousness. So classification of concussion, that has kind of changed throughout the years. There is a group, an expert kind of consensus group that gets together every few years. They started in 2001. They usually meet someplace in Europe. The last two times they met, 2008, 2012, was in Zurich. this again, just to reiterate, it's an expert consensus on guidelines. So this isn't, based on pure research. They discuss all the findings and the research and then make these recommendations. So currently they recommend no grading of an injury. They used to do grade 1, grade 2, grade 3. They used to do simple versus complex. They don't recommend that anymore. Now they just want you to treat every concussion seriously. And the other thing that they really try and hit home is that recovery may take longer in children. And they attribute that to the developing brain, the immature brain might take longer to recover. And we see quite a few pediatric adolescent cases outside of sports concussion. So I think that's really important to keep that in mind as well. So concussion used to be the silent epidemic. I think the media has really helped to bring it to the forefront. The CDC estimates that 3.8 million sports concussions happen each year. That's just sports concussions, and that's attributing like over half probably go unreported. So imagine really how many might be occurring. And loss of consciousness really does not happen a whole lot less than 10% overall. There is an increase in ER visits, whether really more concussions are actually happening or we're more aware of it, or physicians are saying, okay, go to the emergency room because they want to address it. Things are being picked up more. And also only 26%, so about 1/4 of concussions are sports related. They also included bicycle injury in that. That's just through the CDC. So that means another 75% of people that are having concussions are having it from something besides sports. So what we see at Upstate, and others may have different, kind of groups of patients, but we see a lot of pediatrics that may have, fallen on the playground, or falls in older individuals. And again, you might see them for a shoulder or hip problem, but then, by some of their subjective symptoms, it may really come to light that maybe they have a concussion going on as well. So, and the other big category is motor vehicle accidents, motorcycle accidents, any type of trauma like that. You may see a concussion. So, mechanisms of injury. Basically, there is a complex metabolic process that does occur within the brain suddenly, rapid onset. And you're going to see sudden chemical changes. We'll talk about the neurometabolic cascade on the next slide. And also traumatic axonal injury, or DAI, diffuse axonal injury. And just to reiterate, the CT or MRI won't show that type of thing. So just a brief slide on traumatic axonal injury. So this is where we're talking about some stretching of the neurons or shearing of those, so that the messages sometimes are slowed, so people have slow processing, things like that. And also I listed some places where that is more susceptible to the axonal injury, brainstem being one of them, and that kind of plays a role in some of the things that we'll be screening for later. So these are how that coins the term neurometabolic cascade, and they do have a really nice slide that kind of pictures the different ions that increase rapidly after a concussion. I think the big picture here to understand is that there is an energy crisis that happens because of these rapid changes. So you have an increased demand for glucose metabolism, and you have a decrease in the cerebral blood flow. So basically, while this cascade is occurring, which typically should end 7 to 10 days, you have the energy demand meets the supply. So you may have patients that, the first day, they're actually doing okay, but that second day, they try to go to work, they try and go to school, and it hits them. So just kind of know that it is a process, and typical recovery should occur between 7 and 10 days. So this kind of leads me to discuss the physiological theory behind concussion. And this is something that a group out in Buffalo led by Dr. Letty is really pursuing with some of his provocative exercise testing and exercise prescriptions. So he's going on the theory that actually after concussion, there is a dysregulation in the autonomic system. So exercise, which increases blood, demands increased blood flow, demands increased heart rate. In response to that is off, and that is what is causing some of their symptoms. So difficulty maintaining that cerebral blood flow and leading to some of these concussion symptoms that are present. What we're going to talk about towards the end, the subsymptom threshold exercise training, is based on this theory. So recovery from concussion typically should happen in that 7 to 10 days. Only about 80 to 90% of folks will recover in that time frame. There are some other statistics that 95% will recover within 3 months. And at first, research does show that these symptoms have more of a neurological basis, but a lot of times with ongoing symptoms and people being pulled from work, being pulled from school, whatever's playing a role here, that some other non-injury factors may start to take place. Maybe some psychological, anxiety, things like that may kind of overlay the diagnosis of concussion. And that's why, at least when it was really considered more of a silent epidemic, these folks were kind of falling through the cracks in terms of having a true diagnosis because, they were kind of just, nothing shows up in a CT, nothing shows up in an MRI. So you might just be crazy if you, can't handle work or whatever it is. So those kind of psych overlays really do play a role in this with a prolonged diagnosis of concussion. So there is a technical definition called post-concussion syndrome, and the World Health Organization defines it as a persistence of these symptoms underneath after 3 weeks of an injury. So if you still have these 3 weeks later, then you could carry that diagnosis of post-concussion syndrome. Now that being said, there's probably several of us in here right now that have 3 of these symptoms. These are pretty vague symptoms. So it's very hard to make this diagnosis, and even at the concussion management program, someone doesn't get labeled as post-concussion syndrome. We're treating their symptoms. But this diagnosis does exist, and a lot of Dr. Letty's work that I'm going to talk about with the exercise testing is actually specific to the post-concussion syndrome population. So these folks have lingering symptoms. In general, most of the concussion research is done specifically in the sports concussion population as well. I will specifically talk about some other newer research. It is still sports concussion, but it's a little bit more exciting because it pertains specifically to the PT side of it. So just to go over some of the common physical symptoms, I'm not going to read them all to you. Headache and dizziness are probably the most common physical symptoms. You'll hear light and sound sensitivity a lot. So that might be, when you're working with your patients who maybe you're seeing for some other orthopedic diagnosis, these kind of, symptom reports might kind of trigger you that you might be also looking at someone who's dealing with concussion symptoms. They might report balance issues or feeling clumsy or running into things, that kind of thing. Emotional issues, usually their spouses or someone that's coming with them might report some of these, but that they're more irritable than normal. They're not quite themselves. Something is different. They get overwhelmed, or they're very emotional. They're crying at the drop of a hat. They lack motivation where before they were, always out on the, wanted to get to work, get to their sport, whatever it was. So some kind of change in their personality. And then some cognitive symptoms as well. I listed the common ones. Really just poor mental stamina. This may show up in work. This may show up in school. Very slow processing. Sometimes you can actually ask them a question, and it's like, it takes them a while to understand what you said and then respond to what you said. And I think dazed, foggy, and fuzzy are really, they describe those. So that's why I included them up there. It's not very scientific. And then sleep. So this is actually, a question that I would ask them, because this sometimes it leads you to also think about concussion. And you may see someone that is sleeping more than usual. You may see someone that's sleeping less than usual. So that may not help you, but a change in their sleep pattern. And specifically difficulty falling asleep. That is a common one that we see. So again, just in terms of some of your questioning, that might help you to try and figure out if that might be occurring. So the current medical recommendation for someone post-concussion is physical and cognitive rest until they are asymptomatic. And that's all well and good if in 7 to 10 days they have no symptoms. But if at 3 weeks they still have symptoms, and if at 2 months they still have symptoms, how long are we going to have them not going to gym class, out of work, not going to school, whatever it may be, there comes a time when they really should be doing something. Now, at the concussion program at Upstate, we may see people a week after injury. That's great. But we may see people a year after injury. So depending on where they are, how we do the testing. But typically with some of the exercise testing I'm going to talk about, 2 to 3 weeks after injury is about that time that you could do some of the provocative exercise testing that I'll describe in a few minutes. So just limiting, their environmental stimulation. That may mean, not going to a sporting event, not going to the movies, things like that might increase their symptoms. So rest is needed in the beginning, and it may be needed throughout, while they're recovering. But there comes a time where we may have to start adding a little bit in so they can start living, and we don't get some of those secondary effects like depression that we may see in all ages, and they do report that. So the medical management of concussion, typically someone that has a history of perhaps multiple concussions or other risk factors. So folks that may have a history of migraines, ADD or ADHD, may be at higher risk of prolonged symptoms of concussion. History of multiple concussions. Once you have your first concussion, you are 1.5 times up to 5 times more likely to get a second concussion, so that risk does exist. People that are having prolonged recovery maybe should go see a concussion specialist, or they're not getting better and they're having worsening symptoms. That shouldn't happen, so that deserves a medical look. So at the Upstate Concussion Program, we, as you can see, have some different team members that participate. And just to talk a little bit, the MD side, the nurse practitioner side, they may recommend further testing, but a lot of what they're doing is kind of coordinating the care. They'll recommend speech therapy, occupational therapy, PT. Pretty much everybody gets psychological, at least the initial evaluation, and that may be more for counseling. They used to do more of the neurocognitive screening, some of the impact testing that you may have heard about, and I'll talk about that in a second. That's kind of fallen out of favor lately. They don't do that as much. But in terms of medications for the medical side of things, what we're typically seeing is prescriptions for like an Elavil, amitriptyline, which may help with headache or sleep. And that may be, they do prescribe that for some of the athletes depending on where they are in the process. If someone wants to go more of a natural approach, they might prescribe melatonin for sleep or a combination of magnesium or riboflavin for headache. So that's typically what we're seeing. I don't know if others are seeing other prescriptions for some of the concussion symptoms. I included vocational rehab counselor on here because at least in our program, I think as a liaison, especially for the students with the schools, is very important, especially if they're being pulled from school or doing half days from school. I think it's very important to keep that up. And the biggest thing that we're doing as a program is educating the patient, the family, and then school or work, whichever it might be, on how these symptoms are playing a role in their function, why they need rest breaks throughout the day, trying to, hopefully make it easier for the patient and not stress them out when they're dealing with some of these symptoms during their workday or their school day. So some newer imaging, so I said that an MRI or a CT isn't going to really show much. I listed a few. So these, the fMRI and the PET scans, they are looking more at kind of blood flow measures. And actually, Dr. Letty in Buffalo has started to do some exercise testing in combination with looking at functional MRIs to see if an exercise group actually has changes in their functional MRIs. And some of the initial work is pretty promising. It's just a very small number of people right now, so more of a pilot study. But right now, there's really no great neuroimaging technique that is going to say, yes, you have a concussion. There is some newer research that's coming out. Dr. Bazarian talked about this at the Brain Injury Symposium, talking about serum blood markers. And I listed 2 up here that are showing some promise. And the S100B actually is used throughout the world. In some places, they actually use it to predict the use of a CT scan to predict a hemorrhage, so a brain hemorrhage specifically. So basically, if assuming that the protein, so we talked about the concussion actually causing a cellular change within the brain. So if these proteins are crossing over the blood-brain barrier, which is part of the question, because they would obviously have to do that to get into the main bloodstream, could you just prick someone's finger and test their blood within a certain amount of time? So what Dr. Bazarian was talking about was within 6 hours, to see if you're getting a change, and would that indicate that there has been a concussion by this elevated protein in the blood. So just something new that's out there. It's still being researched, but I thought it was very interesting and wanted to share it with you as well. So neuropsych testing, that again, it used to be more commonplace. I think its utilization these days is best when it's done kind of pre-season or to get baseline testing. And even at that, folks can do them and not do very good if they want to. So I think that's why it's kind of fallen out of favor, is it might not be a very good measure of a change in cognition after a concussion. I listed a couple different ones up there. In theory, back, years ago, and they probably used it more, it might help, along with some of the physical testing that we might do with PT, it might also help to say, okay, they're ready to return to play. Their cognition is back up to what it needs to be. And then I listed some of the categories that they're looking at there. So typically, the computerized test takes about 30 minutes. I don't know if a lot of people are seeing their patients have that done, but we're not seeing it as much at Upstate. So, this might just be something I think, again, as a treating therapist, if they're not getting medical follow-up specifically for concussion, just some recommendations that you can make if it's a student or even for somebody who's working to try and adjust their day to make it easier for them to tolerate. So taking rest breaks is a really big one. Hopefully if they're working, their work will allow something like this. I guess if you can smoke during a smoke break, you should be able to take a rest break for your concussion. Avoiding overstimulation. So, for your students, they may have to eat their lunch in a quiet area. Things like that to really avoid increasing their symptoms at a time where really they could take advantage and take a rest break. And just some modifications for academics, just to give them more success. And I also included some physical education accommodations. Really, during this time, they might be clumsy. They might have decreased reaction time. So they are usually immediately taken out of gym class. But if they're still out of gym class for 2 months and they're still just sitting on the sideline, we need to step in and change that, because they really should be doing something. So I put these up here. We do prefer some type of exercise once we take a look at the patient to determine what it should be. But that's preferred to, having to write a report on lacrosse or something like that, and sitting out on the sideline. And another thing, especially that is happening with the student population, is, they are isolated. So during lunchtime, they're by themselves. During gym, they're by themselves. During study hall, they go and sit in the library. So I think it's important to acknowledge that and to try and prevent any secondary depression that could happen from their concussion injury. So goals, what we're working on, at least in our program, this is probably what we all do in physical therapy, is trying to get our patients back to what they were doing safely. But unfortunately, the reality is that sometimes, and we see people that are 3, 4, 5, 6 concussions into it, we may need to establish a new safe level of activity. So all of our patients can't really sometimes get back to that full function, and you all probably see that in your day-to-day work as well. So any questions? Now I'm going to get into the physical therapy assessment part. Any questions so far just on the background, concussion, definitions? Okay. So we're going to go through all of these, and really, I think I have this in a specific chronological order for a reason. So, looking at the neck first before we do vestibular testing, because some of the vestibular testing that we do has really rapid neck motion. So this is designed to go in a specific order, and you may already do this in your practice. So looking at their history, and some of this is mostly for documentation. If someone tells me they have a loss of consciousness, that is not going to change my treatment or my evaluation at all. I do, ask if there is history of migraines. Those symptoms or medical history, things like ADHD, things like that may cause maybe a longer recovery. I do ask about that. At Upstate, we use something called the post-concussion symptom questionnaire because we have to use a functional outcome measure. It is not the best. It does not have great reliability or validity. And again, a lot of those we all have on a regular basis. So if somebody has more specifically, a neck problem that they're dealing with or having neck pain, I may have them do, something better, the neck index, or if they're having dizziness, I may have them do the dizziness handicap inventory, something like that. But we all do this on intake because it is something used throughout the program. But like I said, it really isn't the best one out there. Then before we do a whole lot of moving, I get their resting vitals, and this is going to play a role in some of the provocative exercise testing later. So getting their just resting blood pressure, resting heart rate, just to establish that baseline for when we do the exertion testing. So the cervical screen, and I can't tell you how many times most people come in, oh no, I have a concussion, I have a horrible headache, but my neck's fine. And then you just do your basic range of motion, and, it's all messed up. And, they have all kinds of trigger points. So it's really important to look at the neck because there is really, I think, a strong tie between, the neck holds the head on to the body. So it really functions as one unit. So a lot of times this is an area where we're doing a lot of treatment. So nothing is new here, probably, at least on the top part. Looking at some special testing. So if for those patients that might come in that might subjectively say, oh, my head feels heavy all the time, or they're, the bobblehead kind, or they're sitting there and they literally have to keep their head on the wall because they can't control it. So I included some special tests at the bottom that, may help kind of rule in or rule out some of those cervicogenic type headaches, cervicogenic dizziness type of things. These, the cervical proprioception I probably do more than the other ones. And that being said, at Upstate, we have 2 vestibular certified CTs because there is a large vestibular component that we see with a lot of these patients as well. And then we're doing just our regular musculoskeletal and neurological screen. I think this is important because, like I said, we may have somebody that comes to us after a couple weeks, but we may have someone that comes after a year. And unfortunately, we sometimes catch stuff that may present as concussion, but it's a brain tumor or it's MS or, something that is outside of concussion. And you'll catch some of that with, if you're doing, your manual muscle testing, your coordination testing, looking at gait, things like that. So I think it's important to do that, not in too much depth. Scarring malformation, that's another one that we've talked several times. So things that don't quite add up to concussion. You really shouldn't see anything show up here if it is just a concussion injury. I did put generalized weakness. That might happen, but you shouldn't see isolated weakness. That would not be normal. So visual screening. How many people here do vision screening for any type of diagnosis or feel comfortable with it? I think this is something, especially with this population, and this is within our scope of practice, and I'll include the ones here that I do that I think, would easily give you an indication of, yes, we need to have someone else look at their eyes. It might not be me, but maybe I need to refer to occupational therapist, something like that. These are just some things that your patient might say or might trigger you to think, oh, maybe we really do need to look at the eyes. But I will look at them for everybody. So if they're describing any issues with reading, they lose their place or they don't remember what they read or things are moving on the page or they have difficulty looking at their smartphone or the computer's too bright, the light sensitivity factor, just sitting, these lights, they all hate. So some of those subjective reports can clue you into we need to look more at the eyes. And this isn't just going to be a change in the acuity of their vision. This is how their eyes are processing. So this is more of a visual brain issue, not just an acuity issue. So here I included at least what I look at with my visual. So looking at your ocular range of motion, so just your H-test to just see, are they comfortable looking in all planes? Is it smooth motion? Are they, having to blink a lot? Is this making them dizzy? Sometimes you just get through that and they're ready to fill up on. We do look at acuity with a near visual chart or in the Snellen chart. Doing pursuits, so having them follow smoothly, your target, it should be nice and smooth. It shouldn't be jumpy. and saccades, so going back and forth between two targets. Are they overshooting? Are they undershooting? And again, is this giving them some symptoms? And then also looking at near point convergence, so bringing the target in towards their nose. There is going to be a point where it goes double. Is that within normal limits? And then bringing it out to see when that image fuses again to 1. And if any of these are falling outside the norm or giving them symptoms, then that's a trigger for me to refer to occupational therapy. So I looked at the bottom why vision testing needs to be looked at. I mean, a lot of cranial nerves play a role in that, different parts of the brain. So this is definitely something that can be affected by concussion. They may go to their regular eye doctor and get their regular acuity testing, and everything looks fine. So they come to us and say, well, I've been to the eye doctor, everything's blurry, but the eye doctor said I'm just fine. Well, it's not the acuity of your eyes, it's how they're processing together. So we have a specific neuro-optometrist in town that we refer to who really understands that relationship. So if you see a patient and they're having vision problems, try and not get them to their regular eye doctor first, because they might not understand what really needs to be looked at. And I included a chart on this was from Dr. Kapoor's presentation at the Brain Injury Symposium. I think it's just a nice, combination of everything that you might see from the dry eye, which is very common, to issues. So accommodation is just the ability of the eyes to go from near to far, far to near easily, and that should happen. We're all doing it right now. We're looking in front of us, looking up, looking down, and that should happen smoothly and without symptoms, and things shouldn't be blurry. The other things that we're looking at, so the saccades that I mentioned, the pursuits, that's under the virginal ocular motility, and then the convergence or vergence, that's listed under the third one. So I think this is just overall good kind of chart to summarize some of the deficits that we might see after a brain injury. So vestibular testing, how about, feeling comfortable with that? I think, there are certain ones that we probably learn in school, and I don't know if anyone treats vestibular patients, but, they're very easy to do, and you can pretty much know in a quick amount of time what you might be dealing with. So this is just a little summary on the vestibular system. I'm not going to read that to you, but what we're looking at with some of our questioning is trying to determine if we think it might be a peripheral vestibular problem versus a central peripheral problem, and we would treat them differently, and we see both. So if it is a peripheral vestibular problem, I'm looking at, how long does it last? Is there certain motions that bring that on? Are you getting that spinning feeling? Is this more lightheaded? Also, we do have a lot of patients report ringing in the ears or tinnitus. So if there does seem to be more structural issue, and this again happens more with trauma or assault, where really they might have taken a good blow to the head, then a referral to ENT might be indicated. But if they're, talking about, when I, roll over in bed, I'm getting dizzy, and again, this does happen, then you're looking at some more peripheral vestibular issues, and that included the Hall-Pike and roll test, depending on the canal. So I would definitely screen that. Now, again, I wouldn't do the Hall-Pike if their subjective symptoms are not indicating that it would be present. But I do always do the stabilization. So just very quickly, so the regular VOR, they're maintaining their focus on your nose. You're moving them side to side, and then you quickly stop, and you're seeing if they can stay focused visually on your eyes, or if there's a quick refixation. And if there is, that would indicate a peripheral vestibular loss or hypofunction. If you're looking at the cancellation VOR, your target, your nose, is a moving object, and they're following you back and forth with their head. And if you want, I'm not a vestibular certified therapist, but I understand these tests. I can go through them, if you want afterwards. If they're not able to track you smoothly, then that would indicate a central dysfunction and or having some of these symptoms during that testing. And gaze stabilization, we use a Snellen chart. They're 10 to 15 feet away. They read the lowest line that they can statically without any head motion, and then you get behind them and you're doing 2 motions per second side to side very quickly with their head, and they read the lowest line that they can, again, with head movement. And if they have a more than 2, so 3 line degradation, then that would be a positive test for your dynamic visual acuity. So that would indicate that you should include some vestibular component to your treatment. And a really great study came out by Schneider that actually looked at the role of cervical vestibular treatment for sports concussion. Now, it was a pretty small sample size, but they had their control group that got just education, range of motion exercises, and graded exercise progression, which is what a lot of us do for your concussion patients. Then the other group got a specific vestibular and cervical spine treatment as well as just that first treatment I explained. So in your treatment group, 73% were cleared to return to sport in 8 weeks, where in the control group only 7% were. So I think that, we've been doing the cervical vestibular treatment for a long time combined with our traditional exercise, progression. But this really reinforced that it really can make a difference in getting them back faster. So looking at some balance testing. So some of what we do, this might depend on your population too. If you're looking at an 80-year-old patient or a 5-year-old patient, you may have to change things up. If we're working with a sports population, we really do try and do the best testing, the balanced error scoring system, which is specific for your concussion population. And that's counting the number of errors that they have with specific foot positions. Their eyes are closed during all of them. They're looking at double stance, tandem stance, and single on firm and on foam with their eyes closed. The reliability studies on that are not great, but that is what we are consistently using. I don't know if anybody's using anything else to test for balance with the sports concussion population. Sorry. And depending, so if we're working, with something, not everyone, like I said, that we see is your sports patient. Only probably about 25% are. So we may do something like gait speed or timed up and go because people really might be moving slower. So that might be a really good functional outcome measure. I included dynamic gait index, functional gait assessment, so looking at postural stability while they're having to do certain movement tasks that really might have, some deficits show up with that. And then I included just your traditional balance testing. I think something else, whether you assess it at the beginning or you might use it to kind of test their recovery throughout, is looking at a dual task balance activity. So asking them to do a cognitive task while they're, either standing statically or while they're walking or doing tandem walk, something like that. So there is some evidence out there that even after people are saying that they are asymptomatic, that still their dual task gait speed is decreased after a concussion. So I think it is something that deserves a more, for us to look at a little bit more. And I think some people are doing more research on that as well. Okay, so when should we exercise? That I really want to emphasize, because we can't just let them rest for a year. At some point they need to do something. So some animal research that has kind of delineated a period of time that probably you can start to do some exercise. So they figured out that 0 to 6 days, it really does disrupt the recovery from a concussion. Whereas 14 to 20 days after, if you add exercise, that actually enhances their recovery. And they attribute that to the role of BDNF. So that plays a role in neuroplasticity, which we know a lot about in terms of, neuromotor, progression. So there's some initial studies with exercise. Studies started in 2010, really found, and this again was with the post-concussion syndrome diagnosis group, so folks that are 3 weeks out and even up to 6 months out that he is testing, really found that there were some benefits to low-level exercise for symptom recovery. So this chart right here is pretty much the consensus of graded return to play. So this is from the Zurich 2012, and it's been the same in their last 2 statements. This is probably what a lot of athletic trainers, people, working with the sports teams might be using. And basically what this is meant to do is every 24 hours, so let's say they're at stage 1, they're just at rest, they have no symptoms. So they can try and progress to stage 2, which is light aerobic exercise. If they're able to do just, easy walking, swimming, and it lists some things there without an onset of symptoms, then they can progress to the next stage. So it's basically just a progression of stages that as long as they don't have any symptoms in that stage, they can go to the next one. If they do have a symptom, then they have to go back, they downgrade to the stage before. The issue is you could be at stage 1 or stage 2 forever here. So what do you do? How do you test it, or how do you get past that? And then all the way down to, return to play. So this you can find in all of the Zurich guidelines. So the role really is subsymptom exercise. And I think this goes back to that physiological theory of concussion. So we're looking at trying to increase that blood flow, but not going from 0 to 100. So let's find that point where the symptoms do start, and let's exercise just below that. And let's see if that gets us back faster. So we're not having to just, come home after school every day and sit on the couch. We can actually go outside and walk with the dog and start working on getting better. And more recently, they've been combining some of the subsymptom exercise training with the Zurich return to play guidelines that was just on that chart. So a lot of research on not only the provocative exercise testing, the subsymptom exercise training, but combining that with the return to play protocol. So the Buffalo Concussion Treadmill Test, what has been proposed by Letty out in Buffalo, and it's a provocative test, basically kind of mimicking the bulk protocol. Basically, you're looking for a gradual increase in exertion as measured by heart rate. Now, I'll go through the actual protocol because it is very specific, but you may have to alter this protocol, number one, based on the treadmill that you might have. Our treadmill in upstate only goes up to 12% grade, so you may have to alter it on that. And you may have to alter it based on your patient. So you can do graded exercise testing that doesn't have to be on a treadmill. So if you have a 5-year-old patient that is not able to walk at 3.3 miles per hour on the treadmill, as long as I think you modify it so that you're getting that gradual increase in heart rate and can find a heart rate that may bring an onset of symptoms, then I think you're still basically doing that protocol. So basically it's saying 3.3 miles per hour, you start at 0 incline for 1 minute, the second minute you go up to 2%, and then at 3 minutes and every minute after you increase by 1%. They're recommend that you measure blood pressure every 2 minutes and that you measure heart rate and RPE every minute. Now, having done this personally, it's hard to do all that yourself. Out in Buffalo, they have an automated blood pressure cuff. They have a really nice treadmill. They have the heart rate monitor on. So if you're doing it yourself, maybe you do have a heart rate monitor, so that would be great. That's one less thing that you have to do. Over time, I take an initial blood pressure and then a final blood pressure after they exercise to make sure that it does, correlate as it should. But I admittedly do not take the blood pressure every 2 minutes. If they have to stop and there's an issue, I will take the blood pressure. But as for protocol, that's how it should happen. And again, at upstate, our treadmill only goes up to 12%. So we also have to kind of modify that because we don't have to stop. So what we'll do is go up to 12% and then slowly increase the speed of the treadmill. So we may not always start at 3.3. That's a little fast if you have to end up increasing it because they really shouldn't end up running. It should be a brisk walk. The test. Is there a criteria to stop without the vital signs? Yep. So the test will end based on either an onset of symptoms, so if they have headache, dizziness, whatever, or let's say they started with a 2 out of 10 headache and it increases, okay, so any increase in symptoms, or if they say, I'm too tired, I need to stop. So that would be unrelated to the concussion, possibly, okay? And then you're recording that heart rate and blood pressure. So there's no, set guidelines in terms of the heart rate. It seems all the vital signs for the heart. The heart has to get injured. I ask them another task like simple multiplication with some cognitive question every 2 minutes. So they're looking for a decline. Yeah, but you're at this point you're just measuring the physiological aspect of it. I think if you add the cognitive piece this early, you really might give them symptoms. You just want to see possibly they're going to get through this whole thing and they're going to be just fine. But most of them are not, I will tell you. You really will get a heart rate that will give them their symptoms. But if they do just fine on this, then I would get them off. Actually, it might be the next slide. It's not. But I do list out some other things to do to really challenge them a little bit more. So the reliability, inter-rater is good. The retest reliability is fairly good. And like I said, you may have to modify based on your treadmill or based on your patient. So, your 75-year-old patient, you may have them walk around the track, or wherever you are, walk up and down the hall, trying to get that increased heart rate. And not everybody, if they come in and look like they're about to throw up, this is not something that I would recommend doing that day. You may, be able to send them off, doing something else. This, specifically might be your sports concussion patient. The doctor's sending them to see if they can get cleared to go back to their sport. So you need to be able to give good information as to, yes, they could tolerate the exertion. And then, let's see, I have it in a second. So if they do have onset of a symptom at a specific heart rate parameter, you're going to send them off working at 80% of that heart rate. So sub-symptom threshold. We are combining it with the return to play. So, you may send them off, just with the walking, the first session, but then you may have them, doing some other light exercise that may be specific for their sport. And what we're doing a lot is combining with anything that we found in the previous assessment. So if there is anything that we found with the neck, vestibular system, any balance issues, we would combine that. Should I hit something on there?
What is the manual time? Like at which point do you just say, they haven't complained of any symptoms and not complaining of being exhausted?
Yeah. Yeah. I mean, I haven't really run into that. Usually they will say that they're really tired when you're cranking it up to 4.2.
Is it usually like 20 minutes that people are going, or are they usually going 15?
I would say it really does vary. But if someone gets to about 20 minutes, it probably is about time to get off the treadmill and have them run around the track. But I would say most people, and this is just, percentage-wise, are at about maybe the 8 to 12 minute mark where they're really having to stop. Maureen, would you have anything different to say on that? Okay. Is anybody doing anything like this? Okay. Are you doing the buffalo? Yeah. 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 Okay. So if they don't have any symptoms with it, then other things to have them do. So I will have them run, we have a not a full-size track, but a large track. So have them run, full pace, mile around the track, rapid step-ups, so up and down really fast. I see a lot of, missteps or, timing issues with that. So I find that that's a really good one to combine with that. Ladder drills, grapevines, anything, fast motion to really kind of test them. I like to do the shuttle run, so I have cones set up. Not only are they running to the cone, but they have to reach down and tap the cone. A lot of times that translation and head motion can really set off symptoms, so I find it to be a pretty good test. Any sport-specific drills, so soccer, dribbling around the cones, or football, baseball. I mean, we have a lot of space where we are, so we can have them do some really specific things. And then dual task static and dynamic balance activities. So adding a cognitive task to, something on the go-to ball or on the foam or, tandem or walking or anything like that, I think is really helpful to really challenge them and really, feel confident that you're making that right recommendation to the medical team, like they got through everything and they did just fine. So, really overall, it is an overlap of several different areas that we're working with. And I think as physical therapists, we're really well trained to work with this population because we can assess and treat everything that I mentioned before, except maybe with the vision part of it, but at least you can screen for that and refer appropriately. Balance, we're working on therapeutic exercise, some of that cardiovascular, cervical, vestibular components. So just to give you a good visual as, all the multifactorial treatment that we're doing with that population. And, just to reiterate, I think, this is a population that we should really try and get our hands on earlier than later because down the road they may have, more complications. So I think, working on some of our skills in terms of assessing the vision or vestibular, which maybe we're not as comfortable with, I think is crucial. And then, becoming familiar with some of the provocative exercise testing and being able to modify that based on the patient that is in front of you. And then, again, just, that sub-symptom exercise training. I think I skipped a slide. This one is very important. So this is actually the recommended exercise progression based on that. So this is a pretty slow progression, I would say. Again, most of the research is done in the PCF patient category, but they're recommending, so once you get that threshold heart rate, that you exercise at that for 20 minutes a day, 80% of whatever that is for 2 weeks, and then would slowly increase by 5 to 10 beats per minute. Now, that would take a while to do that. So most of our patients are not going this slowly, but basically the goal is, to get up to 85 to 90% of your age-predicted max heart rate without symptoms, and then start that direct protocol. So sorry, this is a pretty important slide here. This is like that whole progression of exercise. And again, we're doing things a little bit differently and a little bit faster, again, depending on your patient. So, but just in general, you're starting symptom heart rate and progressing as tolerated. Any questions? Yes.
My first question is, you talked early on about the cognitive and physical rest early on.
Yes.
What is your recommendation on initial mental rest right after concussion?
So would this be for a student athlete or?
In the case of population on primary treatment or
athletes, okay. Yeah. So typically, do you want me to repeat the question, Adam? Okay. So he's asking for specific cognitive recommendations for rest after an injury with a sports population. So typically what we would recommend programmatically is that they're still going to school, but that they would have rest breaks, 2 or 3 rest breaks during the day, extra time for tests, quiet area, for times where they're in a large group that they're, eating lunch, like I mentioned earlier, they would be in a quiet area. They might have reduced workload, so having a conversation with the school about, less homework or specifically less reading exercise